inside of the small pelvis. Let's say there are huge branchings of the medicine which is exactly studying, speak about the problems, disorders of this region. And we will start to speak about topographical specificities. But before this, I want to remind for you the anatomy. I want to remind you that pelvis, it is not one, but it is two big compartments. As you remember, we have so-called big pelvis and we have false pelvis. By the way, both these pelvises forms by the pelvic bones, skeleton of them, forms by the pelvic bones, and posteriorly it is the sacrum. Let's say these three bones, right and left pelvic bones. By the way, each pelvic bone, as you remember, has three junction bones. Yeah, in the early ages, it is the synchondrosis, yeah, which is connected to each other by the cartilaginous structures. Then it is become to synastos. Yeah, it means the junction by the bony structures. This is from up to down, iliac bone, ischiadicus bone, and the pubic bone. Pubic bones, right and left, connected to each other by semi-articulation, which is called the symphysis. So remember, please, about it. This is the bony skeleton of the pelvis. How we make division of this bony skeleton? You can write or remember that the pelvis by linea terminalis, subdivided into two compartments. Above the terminal line, we have greater or false pelvis. Below the terminal line, we have the true or lesser or small pelvis. All these names is synonyms. The true pelvis, lesser pelvis, or small pelvis. In the brackets write, please, the structural units of the terminal line from in front to behind. This is superior margin of the pubic symphysis, superior margin of the superior horizontal part of the pubic bone, arcuate line, a linea arcuata, which is located in inner surface of the iliac bone, and promontorium of the sacral bone, which is completely finished. Yeah, the circle of this line. Now we need attention, everybody here. From in front to behind, you can see structural units. The upper margin of the pubic symphysis, upper margin of superior branch of the pubic bone, arcuate line, promontorium, and finally it is passed to the opposite side, and we have the complete circle. So we need attention now to me. Above this line, we have the greater or the false pelvis. Below this line, we have the small or true pelvis. Meaning attention to me. From the organ or, let's say, topographical point of the view, above this arcuate line, we have the organs of the gastrointestinal tract. That is, large intestinal structures, small intestinal structures, and in retroperitoneal space, it is the biggest vessels and nerves, the main sources. Lumbar plexus with its branchings, yeah, aorta abdominalis, inferior caval vein, the lymphatic pathways. Let's say this is abdominal structural unit. Then we look below to this line, we find the mainly genitourinary structural units, together with big vessels and nerves, which is located behind of them. This is the common iliac vessels and subdivision of them into internal, external iliac vessels. Let's say together with the sacral plexus, yeah. Let's say here we have mainly the branchings of the sacral plexus. Let's say remember about it, please, from point of the view of the structural units. Upwards, we have the gastrointestinal structures mainly. Downwards, mainly genital. You can say, but what downwards? We don't have gastro. We have rectum. From gastrointestinal tract in the small pelvis, we have just only the rectum, which has the posterior position about equal speed, but mainly, predominantly, here we have the genitourinary structural units. Now write, please, small or true pelvis has two apertures, has the bony skeleton, has the muscles which is cover the walls, fascia, which is called the pelvic fascia, organs, and loose connective tissue spaces. Let's say we have apertures, we have the skeleton, we have the muscles, which is cover this skeleton, we have the organs, we have the pelvic fascia, we have the loose connective tissue spaces. Now 1 minute, look to me. Write please the apertures of the small pelvis. Upper one we call pelvic inlet, and this is the linea terminalis, which we described 2-3 minutes before. Inferior one we call the pelvic outlet. Pelvic outlet. Now write please from in front to behind. What do you want? I say come on and sit down. What else you need? Now go away from my class. Hurry up. What is give you so many positive emotions? You interrupt my lecture and so smiling, shining by the face you come here. Now go sit down. Why you make this show? 2 times I say you go and sit down. What else you need? You show that you have great behavior. Abnormal if you do. Now continue please. From in front to behind, it is inferior margin of the pubic symphysis. It is inferior margin of tuberous clavicle. And inferiorly it is, posteriorly it is imaginary line, which is connected tip of tuberous clavicle with the apex of coccygeal bone. With the tip of the coccygeal bone. Now 1 minute attention into the picture. This is the picture from downwards. Let's say this is inferior margin of the pubic symphysis. Then it is come to the inferior margin of the tuberous clavicle, and from here we provide the imaginary line which is connected with the tip of the coccygeal bone. Now write please small pelvis from downwards, covered by muscular structures. This is skeletal muscles, it's not the smooth muscles, which is formed the diaphragms of the small pelvis, and they divide it into 2 diaphragms. A deeper one we call pelvic diaphragm, and it is presented by 2 muscles. Main one, it is the musculus levator ani. Musculus levator ani. Functionally, you know, it is lifted the anal portion of the rectum, and it is support the work of the external sphincters. Support the work of the external sphincters. Posterior portion of it we call musculus coccygeus. Musculus coccygeus. Musculus levator ani by itself divided into 3 portional units. From in front to behind, it is the pubococcygeal portion, puborectal portion. Second one, it is pubococcygeal portion. And third one, it is iliococcygeal portion. Let's say puborectal, pubococcygeal, and iliococcygeal portion. All these portions together surrounded the anus from all sides. Minute attention into the picture, please. These three, generally it is one common muscle, as you can see, but we divided it into three portions according to the places of attachment. Yeah? Anterior portion of it, which is attached to the inner surface of the pubic bones, we call puborectal muscle. Muscular fibers here has the transverse direction, and posteriorly they come up to the level of the sacroiliac joints and connected from two sides of it. Middle portion of it, it is pubococcygeal portion. Pubococcygeal muscles, muscular fibers, has oblique direction. They pass from back to in front and from medially to the laterally side. And the most posterior part of it, it is fused with the coccyx. That's why we call it pubococcygeal portion. And the most posterior one, it is iliococcygeal, because it is originated from tendinous center of the diaphragm, which is located in the inner surface of the iliac bones. Muscular fibers pass from in front to behind, and the most posterior part again fused with the tip of the coccyx. Let's say these three muscles together we call musculus levator ani. Why we call them musculus levator ani together? Because all of them originated from the tendinous center, which is located in the inner surface of the iliac bones. All three compartments. One is originated from anterior portion of it, second originated from middle portion, and the last one originated from posterior portion. That's why, due to the common origin, we call it one muscle, which is called musculus levator ani. If you will look posteriorly, just behind of it, you will see second muscle. By the way, it's also originated from the same tendinous center or arch, but it is completely separated from the previous one by deep groove. And again, it is fused with the lateral surface of the coccygeal bones. That's it. Generally, we can say that this is continuation of the previous muscle, but it is totally located behind of this. And finally, back to it, you will see the muscles which is belong to the gluteal muscular structures. This is musculus piriformis. As you remember, it is separated the greater ischiatic aperture into the suprapiriformis and infrapiriformis, but it doesn't belong to the diaphragm, yeah? But it is located in the inner surface of the bony small pelvis. Then we speak about the pelvic diaphragm. We mentioned these two muscles. Number one, it is the proper pelvic diaphragm, which contains three muscles, which I mentioned. And second one, it is the coccygeal muscle, which is also included inside of the pelvic diaphragm. Now write, please, superficially to the mentioned pelvic diaphragm, we have the second diaphragm of the pelvis, which is called a urogenital diaphragm. Urogenital diaphragm again contains two muscles. First one, it is triangular shape, musculus transversus perineae profundus. Musculus transversus perineae profundus. And second one, it is the external sphincter of the urethra. External sphincter of urethra. 1 minute, look in the picture, please. Again, then we look from downwards. You see this triangular shaped muscular unit, which is generally located from two sides. For the females, from the urethra and from vagina. From the males, it is located between the anus and between the external orifice of the urethra. And it forms the perineal region. That's like, it's located more superficially than the pelvic diaphragm. And together with the pelvic diaphragm, it forms the floor of the small pelvis. That's a right, please. Two mentioned diaphragm together forms the floor of the small pelvis. And superficially to the floor of the small pelvis, we have the perineal region. We have the perineal region. Open the brackets and write, please, for the females, it is the external genitalial organs. It is the superficial portion of the urethra. And it is the anal portion of the rectum. For the males, it is the external compartment of the urethra. It is the anal portion of the rectum. It is the external genitals. Now write, please, pelvic and urogenital diaphragm. Pelvic and urogenital diaphragm. From upwards and from downwards. Covered by the parietal layer of the pelvic fascia. Covered by parietal layer of the pelvic fascia. Now 1 minute attention in the picture, please. Which is continuation of the endo-abdominal fascia. As you remember, in retroperitoneal space, we describe several fascias. One from them, it is endo-abdominal fascia. By the way, as you remember, it forms the posterior wall of the retroperitoneal space. Yeah? Anteriorly, it is bordered by parietal peritoneum. Posteriorly, it is bordered by endo-abdominal fascia. Otherwise, we call it transverse fascia, as you remember. Yeah? Let's say, right, please, from upwards, it forms superior urogenital diaphragm and superior pelvic diaphragm fascias, and from downwards, consequently, inferior pelvic and inferior urogenital diaphragm fascias. Except this, parietal layer of the pelvic fascia cover the lateral walls of the small pelvis together with muscles which is located in these lateral walls. Right, please, it is musculus piriformis, obturatorius internus, and muscles which I mentioned for you. Yeah, that's a 1 minute attention to me. What does it mean? If you will look attentively to upper picture, you will see that these blue structures inferiorly split it into two structural units. One is come to the organs and cover the organs, and second come to the walls and cover the walls. Let's say, according to this, pelvic fascia will be divided into the parietal layer, which we describe now with you. Parietal layer cover the diaphragms, which we mentioned, from upwards and from downwards. It forms superior and inferior diaphragmatical fascias. More of this, it is covered the lateral walls, as you can see in the picture, with the muscles, which is located in these lateral walls. By the way, I write also the musculus iliopsoas, which also located in the lateral wall of the small pelvis, much more in anterior compartments. And then you remember by lacuna musculorum, it is descended to the lower extremity and we come to the femoral region. That's why this is also the muscles of the lateral wall. And also you can see that it gives the visceral layer, which is come to the organs and which is covered the organs. So you can write it that visceral layer of the pelvic fascia cover the organs of the small pelvis. In the brackets write, please, especially it is the second floor of the small pelvis, which we call cavum pelvis retroperitonealis or subperitonealis, sub or retroperitonealis. And it forms here the loose connective tissue spaces, visceral loose connective tissue spaces, which we will describe little after. Now, minute attention, look to me. What about is it? Now, if you will imagine that my room, it is generally the small pelvis, and you are the organs which is located in small pelvis, pelvic fascia, which is cover you, it will be your white cords. And between your white cord and between your body will be the visceral loose connective tissue space. But it also will cover all the walls of our room. Now between your white cord and the layer which is covered the walls, we will have parietal loose connective tissue spaces. That's a, remember it please, little after we will discuss it. That's a pelvic fascia forms not one, but two types of the loose connective tissue spaces. One, it is the visceral loose connective tissue, which is located between you and your cord. And second one is parietal, which is located between your cord and parietal layer of the fascia, which is covered the walls. Idea is understandable for you? Very well. Now write, please, the small pelvis topographically divided into two main floors. Floor number one, upper one, we call peritoneal floor of the small pelvis, cavum pelvis peritoneale. Floor number two we call subperitoneal floor of the small pelvis, cavum pelvis subperitoneale. And floor number three, the lowest one, it is the subcutaneous floor of the small pelvis, cavum pelvis subcutanea. Let's say once again, guys, 1 minute attention to me. Then you look to the linea terminalis, below the terminal line, all pelvis, small pelvis. In the future, then I will say pelvis, I will mean just a small pelvis. Let's not repeat it any times. Let's say it is divided into the peritoneal compartment, into the subperitoneal compartment, and into the subcutaneous compartment. Let's write the name of the first one, cavum pelvis peritoneale. Right, please, this is the highest part of the pelvis. And it is the transitional place between the peritoneum, which is covered gastrointestinal structures, and peritoneum, which is covered the uppermost portions of the urogenital structures. So from upwards, it is transitional place of the lowest part of the peritoneum, which is covered the gastrointestinal structures, and from down it is the part of the peritoneum which is covered the uppermost portion of the genitourinary structures. Right, please, borders of it, superiorly peritoneal reflection from the abdominal cavity, and inferiorly this peritoneal reflection on the small pelvis organs. Mainly it is genitourinary organs, as I said before. Right, please, for the males, uppermost cavity of the peritoneum, of the pelvis, contain ampullus of the ductus deferentis, uppermost portion of the urinary bladder, tops of the seminal vesicles, upper portion of the rectum, and excavatio recto vesicalis. Upper portion of the rectum, it is intraperitoneal as you remember, and depression, which is called excavatio recto vesicalis. Excavatio recta vesicalis. 1 minute look in the picture, please. Now let's try to find part of these structures because all of them is not visible. Let's say you can see upper portion of the rectum, you can see the fundus of the urinary bladder. Between these structures you can see depression. That's why I want to mention for you guys that these depressions, and for males and for females, located not in the great pelvis, but they're located in small pelvis. But that is uppermost portion of the small pelvis, between reflection of the peritoneum, which is located in peritoneal cavity, and reflection of the peritoneum, which is located inside of the small pelvis. Now right, please, for the females, it is again upper portion of the rectum. It is the posterior surface of the fornix of vagina. Posterior surface of the uterus. Fundus of the uterus. A lateral and anterior surface of the uterus. Anterior surface of the uterus. A fundus of the urinary bladder. A recessius sinus or pocket, call it how you want. Transverse ligaments of the uterus. Two depressions, excavatia recta uterina and uterovesicalis. And it's traversed into the anterior abdominal wall. Now 1 minute, look in the picture, please. Let's discuss and find this tract. Yeah, also mention, please, that upper portion of the uteral tubes and ovarium. They also located in the superior compartment of the lesser pelvis. Also intraperitoneal structures, cover structures. Now minute attention into the picture. Let's say this is upper third of the rectum. Then you can see transition into the vagina. That is the posteriorly fornix of vagina. That's why you can come to conclusion, guys, that from back side your genitalius is more covered by the peritoneum than from in front. If posteriorly it is reached the level of the vagina and the fornix of it, anteriorly exactly from anterior wall of the uterus, it is traversed into the urinary bladder. Formation of the deepest depression, as you remember, Douglas space, excavatia recta vesicalis, then it is covered the uterus from all the sides, by the way. Then it is formed the second depression, which we call uterovesicalis. It is covered the fundus of the uterus. From two sides, as you remember, it forms the transverse ligaments of the uterus and goes to the lateral bones. And finally, it is the recessius sinus. As you remember here, the peritoneum has, let's say, hyper movement. And it doesn't fuse with the structural units of the anterior wall. Yeah? That's why then your urinary bladder full by the urine, it is pushed this peritoneum to upwards, and peritoneum doesn't cover anterior wall of the urinary bladder. That's why if you will make puncture, for example, by upper margin of the pubic symphysis, you will not damage the peritoneum because it is goes to upwards. It doesn't join here the structural units of the anterior wall. Due to this, we don't have the damage of the peritoneum during our punctural manipulations. Is it understandable for you? Now, right, please. Douglas space. It is the lowest portion of the peritoneal cavity, which is reached the level of the small pelvis, and which is contained the free liquids, pathological free liquids of the peritoneal cavity in the vertical position. In the vertical position. Now, minute attention, guys. This has great meaning for the investigations. As you remember, we make so-called bimanual palpation per vagina. For the males, it is per rectum. And we can palpate it, for example, prolapse. For the females, it is the posterior wall yeah, of the fornix of the vagina. If you find it, the prolapse of it, you understand that the Douglas space is not free. Means inside of it we have liquids possibly, or why not solid structures, touch wood of course, but it can be cancer. That's why it is pressed from upwards the wall, and you can make palpation of it. More of this, you can make puncture of this space to take the cytological material for the future investigation. So remember, please, this is very important. Now continue, please. Second compartment of the small pelvis, we call the subperitoneal compartment. Subperitoneal compartment. Borders, right, please. Superiorly, it is the peritoneal reflection of the pelvis. Inferiorly, it is the pelvic diaphragm. Inferiorly, it is the pelvic diaphragm, in the brackets, right, please, which is covered by the superior fascia of the pelvic diaphragm. In the bracket, that's why you remember, yeah, why not urogenital? You can say me, why pelvic? Simply because urogenital located more superficially. It is located under the pelvic diaphragm. Let's say we are located now above the pelvic diaphragm. From upwards, we have the peritoneal reflection. From downwards, we have upper surface of the pelvic diaphragm, which is covered by superior fascia of the pelvic diaphragm. Now, right, please, inside of this space, we have the part of the pelvic organs, which is covered extraperitoneally, otherwise which is located below the peritoneum. Below the peritoneum. Right, please, it is the middle portion of the rectum for both genders. For the females, it is the main part of the vagina, except the superior portion of the fornix. It is the middle portion of the urethra. For the males, it is located inside of the prostate. It is the prostate. It is the inferior parts of the seminal vesicles. It is the inferior portions of the uteral tubes. Ductus deferens, except the ampullus, which is located in superior compartment. A urinary bladder, except the fundus of it. Common iliac vessels and their subdivision into the external and internal. Consequently, the veins. Lymphatic structures, lymphatic nodes of the small pelvis. Parietal and visceral loose connective tissue spaces. Parietal and visceral loose connective tissue spaces. Now write the next topic name. It is loose connective tissue spaces of the pelvis. And write, please, these loose connective tissues forms between the layers of the pelvic fascia and consequently the neighboring organs, muscles, and the bony skeleton of the pelvis. Neighboring organs, muscles, and the bony skeletons of the pelvis. They divide it into two compartments, parietal and visceral. Right, please, visceral loose connective tissue species. Located between the visceral layer of the pelvic fascia and between adventitia of the organs, which is covered by it. They call by two ways, or peri or para. Peri, it means the loose connective tissue which is surrounding all organ, Para, it means loose connective tissue, which is mainly located from sides of the organ. For example, perivesical space, perirectal space, paraprostatical space, parametral space, and some other small spaces. Let's say in the level of the urinary bladder and the rectum, fat is approximately equally surrounding all these organs. Let's say we call it perispace. If you will look attentively in this picture, you will see the visceral layer of the pelvic fascia, which is shown by an interrupted line here. And between this interrupted line and between the organ wall, you can see the narrow fat. This is visceral loose connective tissue space. Now write, please, the pelvic fascia, parietal layer of the pelvic fascia, gives two sagittal processes, which is anteriorly fused to the internal surface of the pubic bones, a little bit laterally to the pubic symphysis. They traverse from in front to behind in the sagittal plane. They fused with the visceral fascia of the pelvic organs. In the brackets write, please, anteriorly it is bladder, posteriorly it is the rectum, and for females, middle one, it is the uterus. And posteriorly they fuse in the region of the sacroiliac joint. Sacroiliac joint. 1 minute, look in the picture now, please. This is the sagittal septus, which is give the pelvic fascia. You can see that anteriorly they started from the inner surface of the pubic bones. Posteriorly they fuse in the level of the sacroiliac joints. And they located strongly in the sagittal plane. Right, please, between sagittal septus, in the posterior part, there are the aponeurotical structures, which we call aponeurosis peritoneo-perinealis. By the author, we call it Denonville aponeurosis. Denonville aponeurosis, which in right and left sides fuse with the sagittal septus. From upwards, it is fused with the peritoneal reflection, which forms the excavatio recto vesicalis for the males and recto uterina for the females. Peritoneal reflection, which is for the depression, recta vesical for the males and recta uterina for the females. Inferiorly, it is fused with the superior fascia of the pelvic diaphragm. Inferiorly, it is fused with the superior fascia of the pelvic diaphragm. Now, mimic attention into the picture. This structural unit which you see between two sagittal septus. For the females, it is located between the uterus and the rectum. For the males, consequently, it will be between rectum and the urinary bladder. And from upwards, now look please here, this is the same structural unit. It is fused with the reflection of the peritoneum, which is formed a depression for the females between the rectum and the uterus. For the males, it will be between the rectum and the urinary bladder. Yeah? And inferiorly, as you can see, it is fused with the upper surface of the pelvic diaphragm, which is covered by superior fascia of it. Idea is understandable for me. Now write, please, between parietal and visceral layers of pelvic fascia, or between sagittal septus and visceral layers of the pelvic fascia, or sagittal septus and parietal layers of the pelvic fascia. As are three possible combinations between parietal and visceral layers, between sagittal septus and visceral layers, and finally between sagittal septus and parietal layers of the pelvic fascia. We have the formation of the parietal loose connective tissue spaces of the pelvis. Parietal loose connective tissue spaces of the pelvis. Right, please. These spaces surrounded the organs and located superficially to the visceral layer of the pelvic fascia. Space number one we call prevesical space, or otherwise we call it retropubic space. Prevesical or retropubic. Now right, please, it is located between visceral fascia of urinary bladder and between parietal fascia, which is covered the inner surface of the pubic bones and pubic symphysis. From upwards, it is inferior surface of the radius sinus. What does it mean? It is place of the transition, of the peritoneum from the urinary bladder to the anterior wall. Let's say, if by prevesical space you will go to upwards, you will touch the inferior surface of the radius sinus. From downwards, it is superficial fascia of the pelvic diaphragm. Superficial fascia of the pelvic diaphragm. Right, please. Communications of this space. Number one, by canalis femoralis in pathological conditions, and by canalis obturatorius and lacuna vasorum musculorum in normal conditions, by canalis femoralis in pathological conditions, by canalis obturatorius, lacuna vasorum and musculorum normally, it is communicated with the femoral region. Number two, along the neurovascular structures, vessels and nerves, which is supply the urinary bladder. You remember, arteria vesicalis, which is from internal iliac artery. It is the branchings from sacral plexus. It's along these mentioned structures. Right, please. It is communicated with right and left lateral parietal loose connective tissue spaces. Number three, along the same mentioned vessels, it is communicated with perivesical visceral loose connective tissue space, perivesical visceral loose connective tissue space. Minute attention, guys, how it's happened. Now, then the vessels and nerves reach the parietal loose connective tissue. Finally, they perforated the visceral fascia, which is covered the organ, to reach the wall of this organ and supply it. Let's say we come to conclusion that parietal and visceral loose connective tissue communicated to each other. Idea is understandable for you. Now, right, please, two upwards along the lymphatic structures. It is communicated with the abdominal cavity. Primary, it is the retroperitoneal space, because the lymphatic pathways mainly go to the retroperitoneal space. For the females, along the visceral loose connective tissue of the uteral tubes, it is communicated and with the peritoneal cavity. For the males, it doesn't have communication with peritoneal cavity. But for the females, look what is happening, guys. By the visceral loose connective tissue space, it is rich. You remember, for the females, peritoneal cavity, it is open space. For the males, it is closed space. Let's say, due to this specificity, this parietal loose connective tissue for females will have communication with peritoneal cavity. For males, no, only with the retroperitoneal space. Continue, please. It's also communicated with the sheath of the rectus muscle. Sheath of the rectus muscle along the parietal layer of the pelvic fascia, which in anterior wall renamed and called transverse fascia, and form the posterior wall of the rectus sheath below the umbilicus. Don't forget, guys, that transverse fascia below the umbilicus forms the posterior wall of the rectus sheath. But in the same time, it is the same pelvic fascia, yeah, which is cover the walls. That's why along this fascia to the upwards, it will have communication with pelvic and posterior wall of the rectus sheath. That's why, friends, if inside of the posterior compartment of the rectus sheath will be any pus, liquid content, it by gravity forces can be descended into this loose connective tissue space. Remember about it, and it can give formation of the pelvioperitonitis. That's a pelvioperitonitis, inflammation of, so you can write there that pathological processes from the rectus sheath can be descended to the down, to the prevesical space, and can give formation of the pelvioperitonitis. Right, please. Second space we call the retrovesical space. Retrovesical space. It is located between posterior wall of the urinary bladder and peritoneal perineal aponeurosis. Posterior wall of the urinary bladder and denombil aponeurosis. Now, many detention, look in the picture. By the way, for both genders, and for males and for females, it is continuous up to the level of the denombil aponeurosis. You can say me why, and for females also. Simply, guys, because, and for females, we don't have complete junction between sagittal layers of the pelvic fascia and the uterus. That's why from two sides there are the narrow spaces, and through these narrow spaces, yeah, part which is located behind of the urinary bladder communicated up to the level of the denombil aponeurosis. Is it understandable for you? All right, please, communication, borders of it, borders for feet. Anteriorly, it is the visceral fascia which is covered the posterior surface of the urinary bladder. Posteriorly, it is the denombil aponeurosis. From upwards, it is the peritoneal reflection. From downwards, again, the superior fascia of the pelvic diaphragm. Superior fascia of the pelvic diaphragm. Now, right, please, communications of it. In the right and left sides, it is communicated with right and left lateral parietal loose connective tissue spaces. Lateral parietal loose connective tissue spaces. To in front, it is communicated with visceral loose connective tissue space of the urinary bladder. For the females, by visceral loose connective tissue space of the uterus. Along the ductus deferentis, it is communicated with the inguinal ligament, inguinal channel. Along the lateral right and left parietal spaces, along the right and left lateral parietal spaces, it is communicated with retroperitoneal loose connective tissue space. Along the 1 minute, look in the picture, guys. I want to remind you this picture again. Then we study retroperitoneal space, we discuss it. This is a retroperitoneal loose connective tissue, and you can see that without interruption, it is come to the right and left lateral parietal loose connective tissue spaces. Where is located right and left spaces? It is located laterally to the sagittal septus. That's like these two big compartments which you see. They will call them right and left lateral parietal spaces. And along of them, our retrovesical space communicated with retroperitoneal loose connective tissue. Continue, please. Next space, it is retrorectal space. It is located between the denonville. Anteriorly, it is bordered by denonville aponeuros. Posteriorly, it is the parietal fascia, which is covered the sacral bone and the sacroiliac joints. From upwards, it is again peritoneal reflection. From downwards, it is the, again, superior fascia of the pelvic diaphragm. Communications. Right and left, again, with the right and left lateral parietal loose connective tissue spaces. Along of them to the retroperitoneal loose connective tissue space. And of course, by the visceral loose connective tissue space of the rectum. 1 minute attention to the picture. Let's say we call it retrorectal space, but in reality it is starting from the denonville fascia. And from denonville fascia it is continuous up to the parietal layer of the pelvic fascia, which is covered inner surface of the sacral bone. That's all this space we call retrorectal. You can say me why you call it retrorectal if it is partly located in front. Because anterior portion is not good developed. As you can see, the majority of the fat here located immediately behind of the rectum, not in front of it. What is the communication? Look, guys, all these spaces, by the way, we forget to say that from first space, right, please, open the part about the prevesical space. And right that it also communicated with right and left lateral parietal loose connective tissue spaces. That is strong rule, guys. Why? Because 1 minute attention to me. Because all sources of arterial supply and innervation located in right and left parietal loose connective tissue spaces. Let's say right and left parietal loose connective tissue spaces will be connected not only with another parietal loose connective, prevesical, retrorectal, but also with all visceral loose connective tissue spaces. Why? Because vessels and nerves from these spaces will go to the organs, yeah, which is located inside of the pelvis. Let's say the biggest communications will have these right and left lateral parietal loose connective tissue spaces. Idea is understandable, but right, please. Lateral spaces, right and left. Borders, medially it is the sagittal septus. Laterally, it is the parietal layer of the pelvic fascia, which is covered the lateral wall of the pelvis with the muscles, which is located in the lateral wall. Superiorly, again, it is the peritoneal reflection. Inferiorly, it is again the superior fascia of the pelvic diaphragm. Anteriorly, it is the place of the junction between sagittal process and the parietal layer in the level of the lateral surface of the pubic bones, little bit laterally to the symphysis. Posteriorly, the same junction in the level of the sacroiliac joints. In the level of the sacroiliac joints. Let's say 1 minute look, please, here. In the level of the sacroiliac joints, as you can see, sagittal septa and parietal layer of the pelvic fascia join to each other and they become to one structural unit. Now, right, please, inside of these spaces, we have common iliac vessels with their branchings. lymphatic nodes, visceral nerves, sacral plexus, ductus deferens, and it has the huge communications. Right, please, it is connected with all another parietal and visceral loose connective tissue species. To upwards, without interruption, it is continuous to the retroperitoneal loose connective tissue space. Anteriorly, it is communicated with the posterior compartment of the rectus sheath. Again, along the ductus deferens, it is for both genders. For males by ductus deferens, for females by round ligament of the uterus, it is communicated with inguinal channels. By superior and inferior gluteal arteries, it is communicated with the gluteal region, loose connective tissue space. By obturatorius vessels and nerves, why not? It is communicated with anterior femoral region. Anterior femoral region. By dental neurovascular structures. It is communicated with fossa ischio-rectalis. Fossa ischio-rectalis. Open the brackets and write, please. It is the part of the most inferior compartment of the pelvis, which is called the cavum pelvis subcutanea. It is the last compartment of the pelvis, which is called cavum pelvis subcutanea. I want to remind you that pudendal neurovascular bundle by infrapiriformis aperture come to the gluteal region, then by Alpok channel goes to the fossa ischio-rectalis, and here make the innervation and arterial supplement of the rectal anal portion of the rectum. Yeah, that's it. Along these neurovascular structures, we have the last communication. Minute attention to me, guys. In the next semester, you will start to study the surgical diseases. And more times after, we will speak about this space because we will discuss together the pelvioperitonitis. Let's say this is the inflammation of the peritoneum, which is covered the uppermost part of the pelvis, and inflammation of it gives the special clinical sign and symptoms, which we will study together. So remember, please, it is below immediately this second compartment, because here we have the main loose connective tissue spaces inside of the pelvic region. Right, please, last compartment of the pelvis, we call cavum pelvis subcutaneum. It is the part of the pelvis which is located below the pelvic diaphragm. Right, please, borders of it. From upwards, it is inferior fascia of the pelvic diaphragm. Inferior fascia of the pelvic diaphragm. From downwards, it is the skin, which is covered the region of the perineum, and anal rectal compartment, region of the perineum, and anal rectal compartment. All right, please, content of it. Number one, it is subcutaneous fatty tissue. Number two, it is the perineum with external genitalias of the males and females. Number three, it is superficial vessels and nerves, which is supply this region. And number four, it is the deepest part of last compartment, which we call fossa ischio-rectalis. Deepest part of the cavum pelvis subcutanea, we call fossa ischio-rectalis. Open the brackets and write, please. Borders of fossa ischio-rectalis. First of all, write please that this is loose connective tissue space, which is surrounding the anal portion of the rectum from the all sides. It has great practical meaning because here we can have inflammational processes which is originated from the anal portion of the rectum. And in majority of the cases, they have the forms of the fistulas, which make communication between rectum and between subcutaneous fatty tissue of fossa ischiorectalis. 1 minute attention, write and look to me. Such kind of the problems, guys, we call paraproctitis. This is one of the most usual surgically treated problem of the region of the perineum and anal rectal portion. That is formation of the fistula between the rectum and between subcutaneous fatty tissue. What does it mean? Content from the rectum by this fistula become to the subcutaneous fatty tissue, and it makes the putrefacial inflammational process here, which can give even the necrotization. Of course, the problem is treated only surgically. Again, in the next year, then you will study the surgical diseases. We will discuss this problem. Now, write, please, borders of this space. Medially, it is the external sphincter of the rectum. Laterally, it goes up to the region of the tuber ischiaticum. Let's say laterally, it can be extended up to the region of the tuber ischiaticum. Superiorly, it is inferior surface of musculus levator ani. Superiorly, it is inferior surface of musculus levator ani. In the brackets, write please, which is covered by inferior fascia of the pelvic diaphragm. Anteriorly, it is musculus transversus perinei superficialis, not profundus, which is formed urogenital diaphragm, but superficialis, which is located more superficially to it. And posteriorly, it is musculus gluteus maximus. Musculus gluteus maximus, which is located just behind of the anal portion of the rectum. In the brackets, write please, it is the medial inferior margin of this muscle. Medial inferior margin of this muscle. Inferiorly, it is the skin and transitional epithelium of the anal portion of the rectum. Skin and the transitional epithelium of the anal portion of the rectum. Minute attention, look in the picture, please. This is triangular shape in the that is frontal section, guys, immediately from the anal portion, and you can see this triangular shape fatty tissue, which is surrounded from two sides, the anal portion of the rectum, and structural units is visible for you. Yeah, from upwards it is musculus levator ani, from downwards it is the skin, and this is transitional epithelium. From the medial side, it is external sphincter of the anus. From the laterally, it is reached the level of the tuber ischiaticum. Let's say this is the fatty tissue space. Right, please, the depth of this fat from down to upwards, approximately up to 8 centimeters. From back to in front, the depth is decreased. From backside to in front, the depth is decreased, and in front of the rectum, it is near to 2.5 3 centimeters. 2.5 and 3 centimeters. Communications of this space, right please, to in front, it is communicated with the perineal region. In the brackets, write please, along the vessels and the nerves. By pudental channel or Alcott channel, it is communicated with the gluteal region for infrapiriformis aperture, as you remember here. And of course, generally it is communicated with subcutaneous fatty tissue of the perineal region. That's all what I want to give you from the region of the pelvis, guys. We can say that by this, all our theoretical questions of topographical anatomy is finished. That will be the last topic which will be included in your controls. By the way, due to the deficit of the time, guys, now look what I will do. Previously I told you that we will have last control.